بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم. اللهم ارزقني نعمة الإخلاص بوجهك الكريم بكل ما أقول وبكل ما أفعل آمين يا رب العالمين. My topic today is about the glioblastoma multiforme. Glioblastoma is a World Health Organization grade 4 astrocytoma. It is present as large irregular heterogeneous mass with central necrosis and thick peripheral enhancement. It is typically located in the supratentorial white matter, and it is involved the corpus callosum and causes extensive vasogenic edema, and it is present in patients between 50 to 30 to 70 years old, and calcification is extremely rare. On CT scan, glioblastoma multiforme appears as isodense mass with central hypodensity with no calcification, and in MRI present as heterogeneous mass with necrosis, shows high signal intensity, and in FLAIR images high signal of periphery and central mass demonstrate vasogenic edema and early extension, and E1 after contrast usually peripheral enhancement with thick irregular nodular pattern of enhancement, and MRI spectroscope we see decrease in A and elevated choline, and sometimes increase myoinositol level may be present, and diffusion there is no restriction. Let us see some examples of this tumor. Here we see a CT scan of the head without contrast. We see low signal mass lesion in the right occipital region with isodense halo, and it is mass effect on the right lateral ventricle, and some of the edema, or it is crossing the midline here. As we see here, this is the FLAIR images, contrast T1 images, MRI, we see mass lesion with mass effect on the right lateral ventricle, and it is crossing the midline on the corpus callosum and pushing the left lateral ventricle with some dilatation. After contrast, we see irregular enhancement, peripheral enhancement with necrosis in the center, and the edema, as we said, it is crossing the midline. Here, this is the differential diagnosis of glioblastoma. We have the abscess and the metastasis. These are the main differential. In the abscess, we have restricted diffusion, and the abscess, it is thin wall with edema, as we said, but it is smooth wall. And here, this is the metastasis from the CA lung, and we see the edema, as we say, and necrosis here, and there is no restriction. Restriction in the abscess also can be seen in the epidermoid cyst and acute infarction. Here, patient with the glioblastoma multiforme, as we see here, with thick irregular enhancing capsule in the left frontal lobe, with a restriction here due to ischemic changes. Here, this is a butterfly appearance of the glioblastoma involving the bifrontal region with involvement of the corpus callosum here with irregular enhancing wall. And this is the butterfly sign, as we said. Here, this is the spectroscope of this patient with the glioblastoma with left frontal region, as we see here. And we have, this is the normal spectroscope, and we see this is the choline, and this is the creatine, and this is the NAA, and this is the lactate. As we see in this patient, elevated choline and elevated NA. Decrease in AA and elevated lactate in this patient. Here, this is the perfusion. Perfusion imaging allows some insight in the angiogenesis in the tumor, and it is strongly abnormal vessels that tend to be leaky, and the neoplasm has increased permeability in the tumor. We see here, this is the glioblastoma with increased vascularity, and this is the necrosis. Another patient with glioblastoma, low-grade glioblastoma with increased hypovascularity in the this patient has high-grade glioma with increased vascularity, as we see here in the left frontal region. As another patient with increased vascularity in the right frontal region, as we see here and there. Here, this is the tractography, and we see lesion in the left thalamic region with edema and obliteration of the occipital horn. As we see the corticospinal tract on the right side, it is okay, and the left corticospinal tracts are thin in number and decreased fibers, and it is infiltrated by the tumor. Another patient with low-grade astrocytoma, and we see the corticospinal tract on the right side, a little bit deviated due to mass effect of this tumor. Thank you very much for listening, and hoping to see you soon in another talk. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.